of skin, sclera, and mucous membrane caused by hyperbilirubinemia. Scleral icterus can be appreciated when the serum bilirubin is more than 3 mg per deciliter. Imbalance between the bilirubin production and clearance is the reason for jaundice. Normally, 4 mg per kg of bilirubin is produced per day. Differential diagnosis for yellowish discoloration of skin is keratinoderma, which is due to increased consumption of carotenoid. It can be distinguished by sparing of the sclera in keratinoderma. And quinacrine. So, bilirubin metabolism. 80% of the bilirubin is produced from the senescent RBCs and the remainder from other heme containing enzymes like cytochrome. In the reticuloendothelial cells, heme is oxidized to biliverdin with the help of heme oxygenase, and then biliverdin is reduced to bilirubin with the help of biliverdin reductase. Bilirubin, being water insoluble, binds to albumin to form bilirubin-albumin complex and it is transported to the liver. In the liver, bilirubin is uptaken and it is trapped with the help of glutathione reductase, and it is conjugated with the help of UDP glucuronide transferase. The conjugated bilirubin is excreted into the biliary canaliculi with the help of MRP2 protein, and some amount of conjugated bilirubin escapes into the sinusoids with the help of MRP3 protein. This is again brought into the hepatocyte with the help of organic ion transporter 1B1 and 1B3 proteins. The conjugated bilirubin, which is excreted into the duodenum, reaches the intestine where it is acted upon by bacterial beta-glucuronidase and deconjugated, and it forms urobilinogen. 80 to 90% is excreted in feces as stercobilin. 10 to 20% reaches the liver by intrahepatic circulation. A very minor quantity of this urobilinogen escapes into the systemic circulation and is excreted in urine. Now, when there is hemolytic diseases, there is more of unconjugated bilirubin. Since it is insoluble, it is not excreted in the urine. In cases of cholestasis, there is conjugated bilirubin in serum, which is going to be excreted in urine, causing bilirubinuria. Van de Berg reaction is used to estimate the bilirubin level in serum. Here, the bilirubin is made to react with diacetyl sulfonilic acid to form azopigments, which can be analyzed by photometric analysis. Direct bilirubin reacts in the absence of accelerator. This represents the conjugated bilirubin. Total bilirubin reacts after adding the accelerator, which is alcohol. Indirect bilirubin is obtained by eliminating the direct from the total bilirubin. This represents the unconjugated bilirubin. Total serum bilirubin is 1 to 1.5 mg per deciliter. Now, delta bilirubin or biliprotein. This is the fraction of conjugated bilirubin linked to albumin. Its production is increased in cases of cholestasis. It has a longer half-life of 12 to 14 days when compared to the normal bilirubin, which is 4 hours. Significance. Some patients with conjugated hyperbilirubinemia do not show bilirubinuria, as this is bound to albumin and cannot be excreted in urine. Elevated serum bilirubin declines slowly than expected due to the longer half-life. And history taking in jaundice, drug usage including the prescription drugs, native medicines, and also the over-counter drugs. Parenteral exposure including tattooing, IV drug abuse, and also transfusion. Travel history for the food habits and also environmental toxin. Sexual history, alcohol consumption. Other symptoms like high colored urine and clay colored stools can be seen in cholestasis. Fever, arthralgia, malaise can be seen in hepatitis. Physical examination, nutritional status and wasting. Temporal and proximal muscle wasting can be seen in chronic diseases like cirrhosis and pancreatic cancer. Kaiser-Fleischer links can be seen in Wilson's disease. Supraclavicular lymph node and periumbilical lymph nodes can be seen in GI malignancies. Excoriation can be seen in cholestasis. Gynecomastia, testicular atrophy, spider angioma can be seen in hyperestrogenism as in cholestasis. Splenomegaly can be seen in hemolytic jaundice and also portal hypertension. Enlarged and tender liver can be seen in acute hepatitis. Palpable gallbladder can be seen in distal biliary obstruction secondary to carcinomas. Here are some signs of chronic liver failure. Investigations. Alanine aminotransferase and aspartate aminotransferase. Alanine aminotransferase and aspartate aminotransferase are present within the hepatocytes, and it is going to be elevated in conditions of hepatocellular injury, inflammation and necrosis. Usually the alanine aminotransferase levels are more than the aspartate aminotransferase. This is due to rapid destruction of AST by the reticuloendothelial system. And also ALT is more specific for liver. AST is also found in myocardium and skeletal muscles. And ALP, alkaline phosphatase, it is present on the biliary canalicular membrane, so it is going to be elevated in case of cholestasis. But it is not specific as it is also found in bone and other tissues. Gamma glutamyl transferase is also elevated in biliary obstruction, and it is more specific for liver. Albumin, since it has a half-life of 20 days, it is going to be decreased in cases of chronic liver diseases. Prothrombin time can be elevated due to two causes. One, due to vitamin K deficiency, secondary to malabsorption, and otherwise, prothrombin time can be decreased due to decreased clotting factors due to hepatocellular damage. This can be distinguished by giving IV vitamin K. Approach to jaundice. Based on the investigation, we can have isolated elevation of bilirubin or bilirubin and other liver enzymes elevated. In isolated elevation of bilirubin, it can be indirect or direct. In direct hyperbilirubinemia, direct bilirubin is more than 15% of the total fraction. In indirect hyperbilirubinemia, the direct fraction is less than 15% of the total fraction. Bilirubin and other liver enzymes elevated. We have hepatocellular and cholestatic. In hepatocellular diseases, the aminotransferases are elevated out of proportion to the alkaline phosphatase. In cholestatic diseases, ALP is elevated out of proportion to aminotransferase levels. Cholestasis can be intrahepatic or extrahepatic. Now first we will see about the isolated elevation of bilirubin and indirect hyperbilirubinemia. Indirect hyperbilirubinemia can be due to increased bilirubin production as in hemolytic disorders, ineffective erythropoiesis, increased bilirubin production as in massive transfusion and resorption of hematoma, impaired hepatic uptake of bilirubin as occurs with drug intake like rifampicin, propionate, conjugation defects in the liver as in Crigler-Najjar syndrome and Gilbert syndrome. So the hemolytic diseases can be inherited like hereditary spherocytosis, sickle cell anemia or G6PD deficiency. This here usually the serum bilirubin is less than 5 mg per deciliter except in crisis. Chronic hemolysis can cause pigment stones and choledocholithosis. This can cause obstructive jaundice. Acquired causes like microangiopathic hemolytic anemia and paroxysmal nocturnal hemoglobinuria. Ineffective erythropoiesis can be seen in deficiency of iron, vitamin B12 and folic acid. Inherited conditions of indirect hyperbilirubinemia, we have Crigler-Najjar type 1, type 2 and Gilbert syndrome. Here the UDP glucuronal transferase levels are distributed. In type 1 there is no UDP glucuronal transferase. In type 2 there is 10% of normal. In Gilbert syndrome 30% of normal level is present. All are majorly transmitted through autosomal recessive pattern. Gilbert syndrome can also be transmitted as autosomal dominant fashion. In Crigler-Najjar type 1, serum bilirubin is more than 20 mg deciliter, so there is increased risk of cardiac arrest and death usually occurs within infancy. Crigler-Najjar type 2, the bilirubin is between 6 to 20 mg per deciliter. In Gilbert syndrome, it is less than 6 mg per deciliter. Crigler-Najjar type 1 can be treated with liver transplant. Crigler-Najjar type 2 can be treated with phenobarbital as it is an enzyme inducer. It induces the level of UDP glucuronal transferase. Gilbert syndrome does not require any treatment. Direct hyperbilirubinemia can be of two diseases, Dubin-Johnson and Rotor syndrome. In Dubin-Johnson syndrome, MRP2 protein, that is a multi-drug resistance protein which is present on the hepatocyte, excreting the conjugated bilirubin in the biliary canaliculi is defective. It is transmitted by autosomal recessive pattern. Histology, we have black liver due to the accumulation of epinephrine metabolites, which are also excreted through this protein. Rotor syndrome is due to the defect in organic anion transporter 1B1 and 1B3. It is also inherited in autosomal recessive pattern. Now we are moving on to hepatocellular disease. Bilirubin and other liver enzyme anomalies, and the aminotransferase levels are more elevated out of proportion to alkaline phosphatase. We have viral hepatitis, hepatitis A, B, C, D, E, cytomegalovirus and Epstein-Barr virus. This can be ruled out by hepatitis A IgM antibody, hepatitis B surface antigen, core IgM antibody, hepatitis C virus RNA, hepatitis E IgM antibody. Here the ALT will be more than AST and the aminotransferase level will be very much elevated. Alcoholic hepatitis, here the AST by ALT ratio is more than 1. Here there is a more fall in the AST level is decreased due to the defect in due to the pyridoxal phosphate deficiency in alcoholism. AST level is usually less than 300 international unit per liter. Wilson's disease, serum ceruloplasmin is the screening test, and 24-hour copper excretion test is the diagnostic test. Autoimmune hepatitis, autoantibodies including anti-nuclear antibody, anti-smooth muscle antigen antibody, anti-liver kidney microsomal antibody can be seen. Drug induced, it can be two types, predictable and unpredictable. Predictable is dose dependent and it is due to the nature of the drug. Example, paracetamol. Paracetamol produces a toxic metabolite called as N-acetyl para-benzaquinonamine. And unpredictable reactions are also called as the idiosyncratic reactions. These are some genetically predisposed individuals will have this reaction. For example, for isoniazid is metabolized by N-acetyl transferase. Genetically, some people will have decreased levels of N-acetyl transferase. So these people are more prone for isoniazid induced hepatitis. Toxin induced, like Jamaican bush tea and Amanita phyloides. Jamaican bush tea contains pyroxylidine compounds. This causes veno-occlusive disease or sinusoidal obstruction syndrome. Cirrhosis and chronic liver diseases, normal or mildly elevated aminotransferase levels can be seen. Next we are coming to cholestasis. Here the ALP level is elevated out of proportion to aminotransferase level. Based on USG, it can be classified as intrahepatic or extrahepatic. In intrahepatic cholestasis, no dilated ducts. Extrahepatic cholestasis, dilated ducts are seen, and the level of obstruction can be determined by using CT scan or magnetic resonance cholangiopancreatography or endoscopic retrograde cholangiopancreatography. Intrahepatic cholestasis, hepatitis B and C can cause fibrosing cholestatic hepatitis. Drug-induced cholestasis is usually reversible. It can some drugs like OCP and anabolic steroids can cause pure cholestasis. Chlorpromazine and erythromycin acetylate can cause cholestatic hepatitis. Chronic cholestasis can be caused by chlorpromazine. Sometimes it can also cause cirrhosis, which is irreversible. Primary biliary cholangitis, it is an autoimmune condition more commonly seen in middle-aged females. Anti-mitochondrial antibodies are seen. It causes interlobular duct destruction. Primary sclerosing cholangitis, it causes destruction of larger bile ducts and it is mostly associated with irritable bowel syndrome. Vanishing duct syndrome, it can be seen in chronic rejection following liver transplantation and also sarcoidosis. Familial conditions like progressive familial intrahepatic cholestasis, here characteristically the GGT levels are not elevated. Benign recurrent intrahepatic cholestasis, it is a benign condition characterized by episodic episodes of pruritus, cholestasis and jaundice, but it doesn't cause any chronic liver disease. Infiltrative conditions like tuberculosis, lymphoma, amyloidosis. Stauffus syndrome is cholestasis secondary to renal cell carcinoma. And infections like malaria and leptospirosis can also cause intrahepatic cholestasis. Extrahepatic cholestasis, we have benign causes and malignant causes. In benign causes, we have choledocholithiasis. This is stones in common bile duct. It is the most common cause for extrahepatic cholestasis. Postoperative biliary strictures, AIDS cholangiopancreatography, AIDS cholangiopathy. It is secondary to cytomegalovirus or cryptosporidium infection. Chronic pancreatitis, Mirzi syndrome. Mirzi syndrome is obstruction of common bile duct secondary to impaction of gallstone in gallbladder. Malignant causes, we have cholangiocarcinoma, ampullary cancer, gallbladder cancer, malignant involvement of lymph nodes in porta-hepatis. Summary: for jaundice, we have to take thorough history, physical examination, laboratory investigations, from which we can classify it as isolated elevation of bilirubin, and then bilirubin and other liver enzymes elevated. In isolated elevation of bilirubin, we can either have indirect hyperbilirubinemia, where the direct is less than 15%. This can be caused by drugs, inherited conditions like regular Najar and Gilbert's, and also hemolytic anemias and ineffective erythropoiesis. Direct hyperbilirubinemia, where the direct is more than 15% of the total fraction, can be caused by Dubin-Johnson and Rotar. Bilirubin and other liver tests elevated, we can have hepatocellular pattern, where the ALT and AST are elevated out of proportion to ALP. Here we can do viral markers, toxicology, and also ceruloplasmin for Wilson's and autoantibody screening. And in cholestatic pattern, we have ALP out of proportion of ALT. ALP elevated out of proportion to ALT. Here we have to take ultrasound to distinguish between extrahepatic and intrahepatic. In intrahepatic, there will be no duct dilation. We can do autoantibody screening and review drugs. And for extrahepatic cholestasis, we have to do CT, MRCP or ERCP to find the site of obstruction.